A very good afternoon. I would like to kindly thank each one of you for joining us live from MAHSA University, South Janaputra. I'm Samuel David from the Faculty of Health Sciences, MAHSA University, and I'll be moderating today's session. Today's webinar is hosted by the Faculty of Health Sciences, MAHSA University. The title of today's webinar is Blood Flow Restriction Training in Physiotherapy. Dear viewers, before we proceed further, it gives me immense pleasure to share with you about MAHSA International Conference on Health Science and Technology, MAHSA 2021. Kindly hold on. MAHSA International Conference on Health Science and Technology, MAHSA 2021. This conference is scheduled for 17th and 18th September 2021 and it's going to be an online conference. The theme of this conference is going to be moving health sciences forward during Industrial Revolution 4.0 to bring academicians, researchers, educationists, and practitioners in physiotherapy, environmental health, safety, and medical imaging, and other related disciplines to share the latest research on the advancements and developments in the relevant fields towards the fourth industrial revolution, IR 4.0. Hello. Meet our speakers. So we've got our keynote speakers, Professor Dr. Jamal Ashim, Associate Professor Dr. Mohammed. Hello. Dear viewers, sorry for the technical difficulty that we underwent. So the MAHSA International Conference on Health Science and Technology, MAHSA 2021, scheduled for 17th and 18th September 2021, is an online conference. The theme of this conference is moving health sciences forward during Industrial Revolution 4.0 to bring academicians, researchers, educationists, and practitioners in the field of physiotherapy, environmental health and safety, medical imaging, and other related disciplines to share the latest research on the advancements and developments in the relevant fields towards the fourth industrial revolution. Meet our speakers. This conference will be highlighting keynote speakers who are excellent achievers in their respective fields. The keynote speakers of this conference are going to be Professor Dr. Jamal Ashim, Associate Professor Dr. Mohammed Aizar Abdul Manaf, Dr. Nur Azrul Asmi bin Yagya. Our plenary speakers for environmental health is going to be Professor Dr. Zailina Ashim, Professor Dr. Juliana Jalaluddin, the plenary speakers for physiotherapy is going to be Mr. Mohammed Kasi, Mr. Narendra Babu Alagar-Swami. The plenary speakers for medical imaging, Dr. Kamarul Amin Abdullah Abu Bakr, Dr. Muhammad Khalis bin Abdul Karim. Kindly note the important dates regarding the MHS conference. 31st August 2021 will be the deadline for submission of abstracts. 10th September 2021 will be the deadline for full paper submission and also for the deadline for registration. Kindly note that 17th and 18th September of 2021 will be the conference dates. It gives us immense pleasure to invite each one of you to join the MAHSA family in celebrating this conference and to make it a grand success. Once again, we kindly request you for the kind participation in the upcoming conference. For further details and update, kindly visit the website mahsaacademy.com and also the MAHSA Facebook page. If you have any further inquiry, please contact us as mihchest@mahsa.edu.my. Your questions concerning this webinar session can be listed in the chat box for discussion during the QA session. Once again, we would like to extend you a very warm welcome to be the part of MAHSA family during this MHS conference. Dear viewers, kindly note that an e-certificate will be provided for this webinar, and to be eligible for this certificate, please fill in the survey form. The link to the survey will be provided at the end of this seminar and can be found in the comment section. So, regarding today's webinar, it's my pleasure to give an introduction regarding today's topic for the webinar. One of the key challenges faced by physiotherapists working in the fields of orthopedic, neurological, and sports rehabilitation is the impaired physical mobility of clients, induced by muscle weakness, atrophy, and its consequences. A trending training known as blood flow restriction, the abbreviation BFR stands for blood flow restriction training, offers a solution to this challenge. Intriguingly, this training technique can also be easily adopted within the fitness industry, especially in instances where there is limited or no room for high-intensity exercise training. This webinar will focus on the concepts, effects, and refined evidence-based application of BFR training. So it gives me immense pleasure in introducing today's expert speaker on this topic, my colleague and friend, Mr. Ravi Kumar. We are proud to introduce you to our expert speaker for today, Mr. Ravi Kumar Murugesan. Mr. Ravi holds a master's degree in physiotherapy. He has more than 17 years of clinical and academic experience in physiotherapy and has supervised approximately more than 30 students in research. Mr. Ravi specializes in advanced PT in orthopedics, and he also holds a postgraduate degree in health service management. Once again, it's my immense pleasure to invite Mr. Ravi Kumar, our today's expert, to give his talk on BFR. Please, Mr. Ravi Kumar, the stage is all yours.
Thanks, Mr. Sam, for the warm welcome, and also good afternoon, everyone and welcome you all from different time zones. In this webinar, we will have some knowledge sharing based on blood flow restriction training in the physiotherapy. What is blood flow restriction training? Blood flow restriction training is an exercise and rehabilitation modality whereby a resistance exercise, aerobic exercise, or physical therapy movements are performed while using an occlusion strap that has been placed in the proximal aspect of your upper limb or in the lower limb. Occlusion pressure is the key point in setting the training. Okay, the occlusion pressure, we have to set it in such a way that it will partially restrict the arterial inflow to the either upper limb or the lower limb, and it should completely restrict the venous outflow during the exercise. So one more time, I'll repeat it. It partially restricts the arterial inflow and completely restricts the venous outflow during the exercises. There are various synonym terms for blood flow restriction training. Okay, these are the different terms. The prime term is Katsu training, which is from the Katsu is a word that has been derived from the introducer of this technique. It is from Japanese word. Okay, also it is known as occlusion training, or also it is called in some literatures as vascular occlusion training or ischemic training. All these are the synonym terms for blood flow restriction training. The concept of this blood flow restriction training is introduced by Dr. Yoshiaki Sato. Okay, the person who's on the right side picture is Dr. Yoshiaki Sato. He only introduced this concept in around 1966 or roughly around 1970s from Japan. The word Katsu, the Ka, it refers to the additional, and Atsu, it refers to the pressure. So we are giving an additional pressure while we are doing workout in the upper limb or the lower limb. Okay, as in the picture, you can able to see doctor is wearing the Katsu band in his proximal part of his both upper limbs. Okay, first he said this application or this concept he tried over the geriatric patient, and he found out there is a bit improvement that happens in the, usually there is a sarcopenia is the problem that has been seen in the geriatric patient, which could be handled very well by means of this Katsu training or blood flow restriction training. The other benefits, it includes the muscle growth, muscle strength has been improved, and even the oxygen delivery and also utilization of oxygen by the muscle tissue is also find to be improved. What is the reason for this today's discussion in 2021 about a technique which has been discussed in 1970s, roughly around 50 years back? Okay, these are the, if you roughly search BFR training in a PubMed page, you could able to see from 2000 until 2001, we can see around 548 research articles have been published. Okay, particularly if you see for the last decade, that is from 2001 to 2020, there is huge research has been done in this area, and these sort of research only will give us and direction for us to travel in which way, how we have to set this occlusion pressure and what cuff we have to wear. All these are details are because of this bunch of researchers that has been published from 2010 to 2020. That is the prime thing behind the discussion for today's topic. In simple words, what is this blood flow restriction? If anyone is could be from non-medical background also, how it works, how it feels. So this particular picture, what you're seeing is, and doctor is measuring and blood pressure. At least everyone once in a lifetime, you may experience this blood pressure monitoring. Okay, first the doctor will increase the pressure in the cuff to a certain limit. At that time period, we could be able to feel that there is a full obstruction that happens in our upper limb, particularly in the proximal part of the arm where the cuff has been tied. And while the doctor tried to gradually reduce the pressure, okay, from the sphygmomanometer, at one point we could able to feel there is a slight refilling or the pulsation we could able to feel by our own. Okay, imagine at that point or at that pressure point, okay, if the doctor fixed the pressure in the sphygmomanometer and a small weight or a little bit of light weight has been given to you, and if you're working against that weight, imagine how it will feel. That is the exact replica or almost a nearby replica for simple understanding of how the blood flow restriction works. Okay, what is the need for the blood flow restriction training in physiotherapy? Okay, the prime challenges for any physiotherapist who is working in across any sectors, it could be an orthopedic, neurological rehabilitation, sports or cardiorespiratory or geriatric rehabilitation. The prime problem for the physiotherapist faces is uh, muscle atrophy. Either it could be impartially mobilization or immobilization of the structures due to some injury, or any sort of these sort of changes, or age-oriented problems as seen in the geriatric elder age groups. So this muscle atrophy, it leads to poor muscle endurance, as well as it reduces the strength, and these sort of consequences, it goes on as it is. Okay, to the particularly if you see in the geriatric population, the picture here, it shows the left side picture is a cross-sectional area of an young healthy adult thigh muscle. The left side one, the right side one is an older adult where the sarcopenia has been set in. Sarcopenia is the condition where the muscle mass has been reduced as the age grows on. This is one of the prime concern in the geriatric rehabilitation. Or else, coming to the musculoskeletal rehabilitations, imagine a person has undergone an ACL reconstruction. In that person, at least 1 or 2 weeks, there is a partial mobilization or very limited movements will be there in the replaced knee, because to have a good fixation of the transferred ACL, or else the tendon transfer which has been done to reconstruct it. So that site will be very weak in that area. If you're giving any sort of heavy movements or else and resisted exercise of high intensity, then there is a high proportion of getting injury to the structure may happen. So in these sort of areas only, the BFR plays a major role. And also in the neurological rehabilitation, there is an decreased neuromuscular condition or control will happen in these sort of cases. So in these areas, it will be very much helpful. And as the problems, what we said in the previous slide, so for those problems, what we have in our hand is the resistance training. Okay, the option that we have is the resistance. We have to provide resistance training to the muscles in order to prevent the muscle from getting atrophy. So that too, the American College of Sports Medicine in 2009, it says that we have to specifically work on high intensity training, high intensity resisted exercise with an intensity of about 70 to 85% of 1 RM has been recommended. Okay, so imagine in all these sort of rehabilitation procedures, this high intensity exercise with 70 to 85% of 1 RM is not possible. Sometimes there will be limited room for this high intensity exercise will be there, or sometimes it will be totally contraindicated in certain patients. So in these cases, are there any sort of different resistant training we could able to provide, which puts minimal stress to that area and to get a maximal gain out of it? In that only, we can use this BFR. So if you see the BFR, it has a very broad application over different sort of areas like musculoskeletal injuries, sports rehabilitation, neurological rehabilitation. In amputee cases, it's been used, and post-operative arthroscopy cases, it's their ACL repair, and also it has been one of the commonly used thing in the fitness and the strength industry. And recently, there are applications of astronauts are being subjected to this BFR to reduce the detaining effect because of the microgravity environment that has been faced in the space. Okay, this resistance training, it will work on two areas. One, it will be of a low load resistance training, or high load resistance training will be there. If you're going with low load, you are using 20 to 35% of 1 RM, and we are using multiple sets of this one. And the end result, we could able to increase the muscle endurance in that. In case if we are using the high load resistance training with an intensity of greater than 70% of 1 RM for around 6 or less repetitions if we are using, then we could able to see there is a prominent increase in the muscle size as well as the strength. When these two exercises have limitations, then comes this right side box where we are using the BFR, blood flow restriction training, with low load resistance of 25% of 1 RM with high repetitions we are using. In that sort of cases, there is a significant increase in the muscle size and the strength, which almost mimics like a high load resistance training. What the effect we got in the high load resistance training, we could able to get it in the BFR when it combined with low load resistance training. Okay, that is the prime thing that we needed from this novel treatment approach. Okay, if you follow the recent Olympics, okay, we could able to see that athletes will introduce to the world a new training or the recovery strategies that they used to came across for the Olympic preparation. Okay, if you see in 2012 London Olympics, the kinesiotaping is very popular at that time. Most of the Olympic athletes were using the kinesiotaping during either pre, during, or post of their activities. And also in the Rio, if you see 2016, the cupping techniques is one of the prominent technique, or most of the athletes we see some with marks over the upper limb or the lower limb. We could see likewise, if you closely notice in Tokyo 2021 Olympics, that is happened in 2021 Tokyo 2020 Olympics, BFR is one of the common concept that few athletes use this one during their warm-up stages. One of the prime athlete is this Michael Andrew, who is the swimmer in US swimmer team. Okay, and also another athlete is the Galen Rudd. He's a marathon runner. Both of them are using this BFR, and we could able to see some sort of pictures while they are using the one in the warm-up phases. Okay, then we move into the application, how we have to apply this BFR. Okay, so in the BFR, if you look into this right side picture, these are the things that we needed for an good application of a BFR technique. Okay, one is the cuff or the bands of various sizes are there. You could see in this picture for lower limb and as well as the upper limb. And another one, there is an sphygmomanometer to measure the pressure. And the one in the middle, the right color one with a probe, is the ultrasound Doppler, through which we could able to identify the flow of blood in the arteries. So these are some of the basic steps in the application of BFR. One, we have to decide about which type of instrument we are going to use, whether you're going to use a band or cuff or a simple strap, anything like that. Then we have to identify in which area we have to place place the strap or the cuff, and then selection of the cuff width. If you look into this right side picture, the cuff would have and various widths are there. Which cuff width have to select? Because the latest literatures are saying that based on the cuff width, the effect also it will vary. So we have to determine or select the suitable cuff for that particular person. And also the important key step in all this application is determining the occlusion pressure. How much occlusion pressure we have to set for a particular person, because this occlusion pressure is not a constant. Although there is a reference range is there, we couldn't able to set it as a constant for one person. It varies from person to person. Okay, because of this latest tourniquet techniques, particularly what we are using at the third generation tourniquet techniques, they are very safe to use, and we have to choose the right occlusion pressure in order to get a good benefit. And finally, the protocol, which protocol we have to use and what are the parameters of the protocol. First, we will move into the instrument. Basically, we have two types of either it could be bands or the cuff. We will use it in the BFR. Okay, the bands are bit, and we cannot say as an outdated. It's by research wise, it's not that much advised. Whereas the cuffs are the latest one, where a pneumatic pressure can be applied, and the pressure will be monitored through the sphygmomanometer. There are some sort of pros and cons for the bands. The bands are very inexpensive and mostly affordable by any person, so it's easily and readily available. Whereas if you look into the problems, the consistency of the pressure while you're using the bands is very, very low. Sometimes there could be a loosening happen. And also another problem is we couldn't able to measure the exact amount of pressure which is being applied by the bands. So that is one of the prime problem while we are using the bands. And also there is a possibility of bit risks are also there. Whereas when you use this pneumatic cuffs, particularly the third generation pneumatic cuff or the recent one, if you're using it, they are very safe and easy to apply. Okay, and also the ability of measuring the LOP, it refers to the limb occlusion pressure. That is the occlusion pressure we have to set it. So it is easy to measure the limb occlusion pressure, and it will be constant pressure will be held throughout the treatment. And also there is an built-in safety mechanism of there. So the probability of having the risk of injury is very, very minimal. Okay, this tourniquet system, the Delphi tourniquet system, is the latest one, the third generation tourniquet system. Okay, so through this sort of research that I told from 2010 to 2020, these sort of things are get updated, and the risk of this problems while we are using the BFR is very much minimized. So look into the bottom one. The risk of this tourniquet complications, or else getting the tourniquet complications, are very, very low nowadays. It ranges from 0.04 to 0.8%. Okay, according to a research has been done by is published in the Journal of Bone and Joint Surgery. And also there is another key indicator. Most of us will think that there is a possibility of getting some sort of thrombus or the vascular complications are there. So to nullify that problem, you look into the second study which has been done by Clark et al. Okay, they shows that there are some sort of key important biomechanical marker to identify whether there is any sort of clotting mechanisms happens, or the fibrinogen, D-dimer, or the C-reactive protein are being monitored immediately after one bout of exercise, or also they monitored it after 4 weeks of BFR. Okay, even immediately after it, or also 4 weeks after the BFR, it doesn't show any sort of changes in these three biomechanical markers, which research-wise prove that it is a very safe technique to do so with this third generation pneumatic cuffs. Okay, then the third part is where we have to place this cuff or the band. Okay, in the upper limb, the prime spot is just under the deltoid tuberosity, where this deltoid muscle will get inserted on the lateral part. The deltoid tuberosity, this is the exact area where we have to wrap the cuff at the band. Okay, the reason behind it, the concept over here is we need to completely occlude the cephalic vein. Okay, so which is a bit more prominent in this area. So this site is an very much essential area to wear the cuff. And in case of lower limb, the location of wrapping the strap or the band is around the greater trochanter. Okay, so greater trochanter is a very easy bony landmark on the lateral side of your thigh. We could able to wrap around that area. And here the prime vein that we are focusing to occlude or to compress is the external iliac vein, particularly the femoral, and the deep vein of the thigh is the one which is bit focused towards in this area. Okay, then the third one is selection of cuff or the band width. As I already told, the width of the cuff or the band also plays a major role in altering the occlusion pressure and also the effect thereby. There are two sort of cuffs or categories are being there. One is called narrow cuff and another one is called wider cuff. Narrow cuff have an breadth of about 5 centimeter around that range, whereas the wider cuff is around the range of 13 centimeters there. Okay, so if you are using the wider cuff, the occlusion pressure will be bit less. Okay, around, for example, if the same person, if you're using wider cuff, around 90 to 120 millimeter of mercury is roughly estimated cuff pressure. Whereas if you're using a narrow cuff, the occlusion pressure, it should be higher. It's around 160 to 180 millimeter of mercury is needed. And also in most of the researches, it's been proved that narrow cuffs are more research wise, it's more effective when compared with the wider cuff. So narrow cuff is the most choice of the researchers in many articles. Okay, then we will move into how to determine the occlusion pressure while using the pneumatic cuff. You can see in this pyramid, there are three regions are there. Okay, we have to roughly work on this green zone. Okay, this green zone is the ideal zone which we have to work on. All this pressure range, what it has been given in this three range, are an approximate figure or approximate millimeters of mercury of pressure has been given over here, because the occlusion, the real limb occlusion pressure will vary from person to person. So see, out of 10, we have to check with the clients, like they have to give their perceived compression level. Okay, you are wearing them around their upper limb or the lower limb. They will have the perception out of 10 how much they feel it is of. If they feel it 1 to 10, or uh, if the pressure is less than 100 mmHg in the upper limb or less than 150 mmHg in the lower limb, then we are in the lower zone. In that one, there is no very poor possibility of getting obstructing the arterial blood pressure, and we couldn't able to completely obstruct the venous blood. Whereas in the mid zone, this is the ideal zone. In the perceived scale, the person have to range it around 7 to 8. It is only a general perception around it. If it's not there, then we can go with this range also. The upper limb, if you're going to do it for the upper limb, it should be around 100 to 200, 220 millimeter of mercury is the average range, and also in the lower extremity, 150 to 250 millimeter of mercury is the ideal range. Okay, this is also an approximate range only. Whereas if you're going into this one, 10 out of 10 of perceived compression, then we are going beyond the occlusion pressure, where both the artery as well as the vein has been completely occluded. Even you couldn't able to feel the pulsation in the distal part of the superficial artery. For example, if you're going with the upper limb, radial arteries pulsation, you have to cross check it in each of this pressure range. And also if you're going for the lower limb, you have to check with the posterior tibial artery. Okay, then how to determine this occlusion pressure? Okay, there are three ways that we could able to determine this occlusion pressure. One is the fixed occlusion pressure by, like what we said, we have to go in this 1 to 5 range or 7 to 8 out of 10. That is being fixed when you are using and straps or something like that. But that is not a personalized one. There is a possibility of occlusion is more in those sort of things. So we will neglect this one. And there is a second method of assessing the occlusion pressure by using the systolic blood pressure. We have to check with the clients how much is their systolic blood pressure, and we have to work out in the 130% of systolic blood pressure. For example, if 100 millimeter of mercury is their systolic blood pressure, then the pressure what we have to set as an occlusion pressure is around 130. Okay, we have to set it in that one. And this method of determining the occlusion pressure is also, it is proven inaccurate and is not being used nowadays. Now, after this, all these sort of latest researchers, okay, this right side one is the best one to determine the occlusion pressure. They give two terms. One is the limb occlusion pressure, LOP, or arterial occlusion pressure. These are the key concepts in this entire application of BFR. What is this limb occlusion pressure or arterial occlusion pressure? It has been defined as a minimum pressure required to stop the flow of arterial blood into the limb distal to the cuff. Okay, we are increasing the pressure at one point of time. We could able to feel that the artery has been completely occluded. There is no more arterial blood flow beyond that cuff. It's been wagged from that point. So that pressure is called the limb occlusion pressure. Once you identify the limb occlusion pressure, then you have to, the recommended zone of using the occlusion pressure is around 40 to 80% of limb occlusion pressure. For example, if a person's limb occlusion pressure is 100 millimeter of mercury, we can work anywhere around that 40 millimeter of mercury to 80 millimeter of mercury. So 40 to 80% of LOP or AOP is the recommended occlusion pressure for that person. Okay, so this is very, very essential thing, one of the key steps in in this application of BFR. And there are many researches. There is a range, wide range is there, like 40 to 80 range is there. Which range has been a bit better in an evidence-based manner? Means if they look into the one, 80% of limb occlusion pressure has been set and you are working with a low load, then it gives a good output when we compare with the 40% of limb occlusion pressure or 60% of limb occlusion pressure. Even if you work out with that 80% of limb occlusion pressure, even after 6 weeks also, the training effect is being prominently noted in the limb by an experiment or the research it's been done by the Lechery et al. 2018. He reported in the one. Okay, how to identify exactly this limb occlusion pressure or arterial occlusion pressure? In that area only, we need this instrument called the Doppler, ultrasound Doppler, okay, through which we could able to audibly hear the blood flow happens in the superficial or any sort of, mostly in the superficial arteries. So in order to identify this limb occlusion pressure, we have to place our client in any position, and we have to put this pneumatic cuff in the proximal part, either in the upper limb or in the lower limb. Since here in this picture, it has been tied over around the greater trochanter. And with a moderate pressure, you have to tie it, and then it should be connected to the sphygmomanometer. Once it's been done, then you have to palpate the superficial artery's pulsation. Here it is the posterior tibial artery. We can able to palpate it just posterior to your medial malleolus. We could able to palpate it. Once you locate the posterior tibial artery pulsation, then what we have to do, then you have to use the Doppler ultrasound, and we have to once you place it over there where it's been superficial, we could able to hear the audible sound of the blood passage through the machine. Okay, it will be something like an up and down, an audible voice can be here. Okay, once you could able to locate that exact spot, then what you have to do, then you have to slowly increase the pressure of this cuff by inflating this cuff by using the sphygmomanometer. Okay, gradually one side you have to notice this in the same position itself. You have to keep the ultrasound probe, and you have to notice the blood flow in the artery. And other side, you have to slowly, gradually, you have to increase the pressure in the cuff. At one point, okay, at 1 point of millimeter of mercury, the sound will be totally absent, or it will be totally, you couldn't able to audibly hear it. That point of pressure, you have to notice it down. That pressure is the exact limb occlusion pressure or arterial occlusion pressure. This is the one which we needed. Okay, so once you identify the limb occlusion pressure, then we have to work out around anywhere around that 40 to 80% of that range is being set as an occlusion pressure for BFR. Okay, one more critical thing in this one is for this person itself. For this person, for example, the limb occlusion pressure is 180 at this position. If you change the position of this person to sitting, okay, or else in standing, if you measure the limb occlusion pressure of this person with the same cuff, with the same procedure, there could be a variation will be there. So the pressure what you identify now in this one is precisely for this position, and also for this cuff width. Cuff width also plays a major role in determining the occlusion pressure. If you're using a wider cuff for this same person in the same position, there will be a variation will be seen in the limb occlusion pressure. So the pressure what you notice now is being specifically for this person at this position for this cuff width. Okay, it is very, very specific. Okay, what are the different training protocols are there, or different modes of BFR? Okay, most common mode is the one what we are seeing in the left hand side of this slide, that is the BFR with lower load BFR. Okay, low load, it refers to 20 to 40%, or even some literature says 20 to 35% of 1 RM. that is called as low load BFR. Okay, this is the one of the commonest mode that we used in most of the researches. And either we can use this one for shorter duration. Shorter duration, it ranges from 1 to 3 weeks of training. If for longer duration, it goes beyond 3 weeks, it could go until 6 weeks or to 8 weeks also. And the second mode of BFR is BFR-AE, that refers to the aerobic exercise. Okay, we can apply this BFR cuff to the upper limb or lower limb or bilaterally over the both lower limbs, the proximal part, and we can ask the person to do the walking or the cycling exercises. This mode is called BFR aerobic exercise. In case we may come up with certain sort of situations where the person is bedridden, or immediately they came up of a reconstruction of ACL, some in these sort of situations, or there is any sort of fracture is there where we couldn't able to move the limbs in that sort of area where the movement is limited, then we can go for this passive mode of BFR. That is also been proven to be effective in certain sort of areas where there has been immobilization is there, or movement has been restricted, or immediately after any sort of surgeries where we couldn't able to put the surgical site under stress. And the other mode, which is, since this mode is still under the hypothetical mode or under the hypothesis, not it be proven by any research, BFR combined with electrical stimulation is also another mode is there, but it too confirmed with some research studies. Okay, training protocol for low load BFR. Okay, so according to this Patterson and the Hughes research report, okay, which has been published in the Frontiers in Physiology journal in 2019, they set and fixed protocol for all these modes. Okay, this mode, low load BFR, is the one of the commonest mode. Already we saw it as the frequency. What frequency we have to use it is 2 to 3 times a week. Okay, if we are going for a long-term BFR, that is more than 3 weeks, you are planned to give the BFR, then you choose 2 to 3 times a week frequency. In case if you're going for a short term, then you can use for 1 to 2 times a week for it's around 1 to 3 weeks. It's been set as a short term BFR. Okay, load, at what intensity we have to work on it? 20 to 40% of 1 RM we have to choose it. How many sets of exercise we have to do? 2 to 4 sets we have to do. And mostly this narrow cuff has been mostly preferred by the researchers. And limb occlusion pressure range, anywhere we can work it from 40% to 80% of limb occlusion pressure, we can work on it. And how many repetitions we have to do? Overall, we have to do 75 reps for that particular muscle. In 4 sets we have to do. First set, we have to do 30 repetitions. Then we have to go for a 30 to 60 seconds of a short rest. And then we have to do 15 repetitions, second set, with a break, a short rest, and then 15 repetitions, rest, and then 15. Overall, if you look into it, it has been done in 4 sets for 75 reps we have to do it. Okay, so this is how either the restriction form, either you can do it in a continuous mode or intermittent mode. Certain persons, they could feel that there could be some sort of different sensation is there. They are telling that there is an excess pain is there. They want to give some sort of rest. Means you can go with the intermittent mode, where temporarily you can release the pressure, and after that you can go with the second set. Okay, when you have to execute the treatment, or else you have to wind up the treatment, means sometimes if there is any sort of concentric failure happens in the muscle is totally fatigued, then we can go for we can wind up the treatment. Or else when the planned repetitions, okay, when the planned repetition is being reached, then you can go for the winding up the treatment. Okay, then the second mode is the BFR aerobic exercise. In this mode, there is a slight variation is there. Okay, the frequency is almost similar. The intensity what we are working is less than 50% of VO2 max. We have to select it for that person, and we have to work out with this intensity. And then the restriction time, it is 5 to either anywhere it range from 5 to 20 minutes. Okay, and the limb occlusion pressure is same as 40 to 80% of the LOP. We have to work on it. And what sort of exercise mode we have to use it? Either cycling or walking can be used. in this BFR with aerobic exercise. And the third mode, as I said, when there is an bedridden person is there, or movement has been contraindicated, or in immobilized state is there, then you can go for this passive BFR. In the passive BFR, you can do this technique 1 or 2 times per day, okay? And restriction time, the max, it will be in continuous mode only. In this passive BFR, you have to go only with continuous restriction for 5 minutes. How many sets we have to go? 3 to 5 sets we can go with it. If we need, we can go for a short break in between 3 to 5 minutes in between the sets. And you have to notice this one, the limb occlusion pressure, we have to set it a bit slightly higher than the other 2 modes. Here, the limb occlusion pressure, if you watch it, it will be anywhere range from 70 to 90% of limb occlusion pressure. In this range, you have to work when you're going with passive BFR. Whereas in the previous 2 modes, we went from 40 to 80% range. Okay. Then what are the contraindications? So any sort of thing that has been related to clot formation in the arteries or unstable blood pressure is there, then we have to go for the one. They like look into the one DVT, pregnancy, varicose vein. If there is unstable or fluctuating blood pressure is there, or cardiac disease. Another one, rhabdomyolysis. In that one, the muscle protein has been automatically destructed. In these sort of cases, you have to this treatment has been contraindicated. And precautions, we have to notice it down. If there is any sort of subcutaneous hemorrhage, you could see below the site of the cuff, or else if there is any numbness is there, or excess domes has been set down, then we have to be precautious in that. What is the effect of this low load BFR training? This low load BFR training, it creates this 3 sort of things within a muscle. Okay, already we know that it completely obstructs the venous blood flow or venous outflow. It completely restricted. So, and also it restricts the arterial blood flow. So it creates a low oxygen environment in the muscles, either in upper limb or the lower limb where you go down. So it creates a low oxygen environment. This low oxygen environment will release the nitric oxide. This nitric oxide will in turn, there is an induced and angiogenesis will be induced, and also it indirectly activates the satellite cells of the muscles, and thereby it increases the muscle mass. And high metabolite environment. You're working with obstruction of your venous return, complete obstruction of your venous return. So what happens? The lactate that has been accumulated because of this exercise, it creates a high metabolite environment. This excess lactate accumulation in the muscle, it induces or it creates an systemic response to produce growth hormones by stimulating the pituitary gland. And also blood pooling also will happen in the distal part from the application of your cuff. And this picture will give you an idea how this one works. Blood pooling, look into it. Blood pooling, this picture will give you an identification where the vein is being completely obstructed. Okay, whereas the artery, there is a restriction in the blood flow in the arteries there. Okay, so if you're doing like that, then what happens? It creates the swelling in the cell. Cell swelling will happen. This cell swelling will in turn activates the mTOR and MAPK, and also it inhibits the catabolism of the muscle. Breakdown of the muscle will be inhibited. Thereby, if the breakdown is inhibited, automatically the anabolism is be increased, and increase in the muscle mass will be noticed. And also, if there is any sort of high metabolite accumulation is there, as I already told, the lactate accumulation in the blood, it stimulates the pituitary gland. Thereby, it releases the growth hormone. This growth hormone release certain sort of factors called insulin growth factors or insulin-like growth factors, and also it release the and improve the collagen synthesis in the muscle. These 2 mechanisms will cause the, or else the particularly this IGF-1 will cause the or stimulate the satellite cell to get fused to the myofibrils. If it gets fused, then there is a cell fusion happens, and it induces the muscle growth in the muscle fiber size also, or the circumference also get increased. Another pathway is when you do this BFR, low load BFR, the nitric oxide will be released, as I already told. This nitric oxide will activate this satellite cell, and this satellite cell will get attached or fused with the myofibrils. This fusion will later increase the muscle mass. Okay, these are the mechanisms through which we get an increase in the muscle mass will be seen after a certain period of BFR training. And this one is the comparison of various resistance training has been done with high intensity, low intensity, as well as the low load. In that one, very particular key things I just want to go through it. As I already know the training mode, you guys know about it. 70 to 80% we used in high intensity, 20 to 30% of 1 RM we used in the BFR plus low intensity, as well as the same 20 to 35% in BFR with low intensity will be there. Okay, then growth hormones. You look into it, when during the high intensity exercise, there is 100-fold increase in the growth hormone has been noticed down. Whereas if you're combining the BFR with low intensity exercises, there is 1.7 times greater than high intensity training increase of growth hormones has been noticed down, which also favors the BFR. And also if you look into it, the time adaptation, this is very crucial. The time adaptation for high intensity exercise, it roughly takes around 12 weeks, okay, to get a real change happens over in the muscle. Whereas that sort of changes will happen very quickly. Even in 2 weeks also, we could able to see the changes in forms of strength as well as the hypertrophy is being seen in the BFR when combined with low intensity exercises. So this is what how the BFR with low intensity exercise differ from other modes of resistance training. Okay, then we will move into a bit of evidence-based approach. Okay, nowadays everywhere we have to go with any sort of things, have to speak in terms of evidence-based research. This particular article or the research has been published in the Journal of Clinical Medicine. It's a systematic review. In this one, in this research, what they did, they took the patients of anterior cruciate ligament reconstruction patient, they took along with knee OA, both patients, they took it and they compare with the blood flow restriction training versus non-occlusion training, like the normal training, what we do, the traditional trainings like quadriceps exercise, strengthening exercise we will do. Here, another group has been done with blood flow restriction training with low load exercises. In that one, it's been found out that there is a significant increase in the cross-sectional area of quadriceps muscle, and also there is a significant improvement in the pain has been noticed, as well as it indirectly improves the quality and the functions of the person. Okay, so this article or this systematic review favors the application of low load BFR after ACL reconstruction or in OEAD patients where there is an atrophy of quadriceps muscle will be there. Okay, then this is another randomized control trial. It has been done by NHS, National Health Service of UK. Okay, immediately after or in the early rehabilitation of anterior cruciate ligament reconstruction patient, they did this BFR training with low load for one group, and then another group went with a traditional high intensity resistance training has been given, and it's been found out that low intensity BFR training is as equal in improving the hypertrophy and the strength as high intensity exercise for this group. And also they found out that in particularly the BFR combined with low intensity exercises, there is a greater reduction has been seen in the knee joint pain as well as in the effusion. I think so, which will be one of the prime target in the early stage of ACL reconstruction person for any physiotherapist. Okay, another one, if you've been interested in neurological rehabilitation, then this particular article will be a bit an eye-opening for you. Are there any sort of crossover effect happens when we use the BFR? it means we are providing BFR training to the unilateral side, probably right side. Are there any sort of crossover effect has been noticed in the left side? Okay, this study shows that there is an greater increase in the muscle strength as well as in the circumference of the limb has been noticed in the same side, as well as there is a bit improvement has been noticed in the opposite side, the contralateral side also. There is an improvement in the strength is being noticed down in the contralateral side. Mostly it could be because of this crossover effect happen. So it is also a randomized controlled trial, and we could able to use it in case where if there is any sort of immobilization is been recommended for one limb, where we couldn't able to do any sort of training over that limb, means we can do this training over the opposite limb to get this crossover effect in the immobilized limb. And this particular article, it has been, or the research has been done from NASA, and it has been reported under a NASA technical report service. Here, they want to look into it how the unloading of the limb, like in the microgravity environment. If probably we can use this one, and they want to look into it how the astronauts are being subjected to microgravity environment. This microgravity will decrease the muscle strength in our particularly in the lower limb muscles or throughout the body also. They want to do and research in this one. And this one, what they did an unilateral lower limb suspension. They suspended a lower limb. Okay, they didn't wait back that lower limb until the treatment period. Okay, and they found out that for that unilateral lower limb suspension limb, they gave this BFR. Other limb, they went with the normal resisted training, and they found it out there is an very minimal muscle loss is there, and also there is an muscle cross-section area of the muscle is also being maintained, and the muscle endurance is also being maintained in the unilateral lower limb suspended side. Okay, the same sort of thing in microgravity environment, whether this BFR could be applicable in this space, like particularly in the astronauts and all. There is a study, it's been released in 2019 in Frontiers in Physiology. Okay, here what they used is high intensity blood flow restriction training. They used in this microgravity environment, and they found it out there is an betterment in the muscle mass, as well as the circumference of the muscle is also being noticed while you're doing this exercise with high intensity BFR in the microgravity environment. Okay, this particular study, it says there is an option. Till now, whatever we saw, all these sort of studies have been done over to look into whether any sort of improvement happens in the muscle tissue, muscle connective tissue. Apart from that, this particular article just go beyond this one. There are other connective tissues are there in the body, like the tendons, which is also will get affected if there is prolonged immobilization is there. The morphology and the mechanical adaptations or the mechanical properties of the tendons also will get altered. So what they did over here, they gave the low load BFR to the Achilles tendon, and they study are there any sort of morphological and mechanical adaptations happen in this tendon or not. There is this finding. It says that there is an improvement in the morphological and the mechanical properties of the Achilles tendon is being noted. This one is the first evidence that low load BFR can be used even outside the muscles. It shows there is an improvement has been seen in the connective tissues like tendons. So it could be used in the tendon injuries also in the future. Okay, then another application is over the elder population or older adult population. In this one, they went for low load BFR with aerobic exercise. Okay, aerobic exercise they did it, and they show a greater improvement to minimize the sarcopenia. Okay, the effect of sarcopenia has been minimized in this particular age group. with the help of this BFR with aerobic exercise in the geriatric population. And in sports, in the athletes also, in the sports rehabilitation also, it proves that BFR works well. Okay, this particular picture, what you're seeing on the right side is Michael Andrew, and Olympic medalist and gold medal Olympic medalist in the swimming competition, particularly from US Olympic team. He is using this BFR, particularly from the katsu. Okay, katsu training he used on the cuffs. This is one of the picture and during his workout, and it says it could be used in the sports, improving the sports performance. And this particular article not only it shows the improvement in terms of strength as well as in the muscle size, but also it shows there is an improvement in the sports performance, like they could able to improvise their time and like that for in short distance running or these sort of things. The sports performance also is improved in this sort of athletes has been noticed down through this study. And another one, this is also a bit fascinating study if you're a bit interested in the neurological rehabilitation. This study has been done by the founder itself, Yokiyashi Sato. Okay, so here what they did, they are giving a single arm curl up resistance training to one side upper limb, and they are measuring are there any sort of changes that happens in the contralateral cerebrum. Okay, it has been noticed that there is an increase in the cerebral blood flow has been noticed down in the contralateral side. Okay, and the BFR could be used in the cardiac coronary artery disease persons also. These are the evidence, and even immediately after the cardiovascular surgeries also it has been used, and the applications has been proved effective. And another key area is the COPD. COPD and muscle loss is always an interlinked problem in the COPD. The peripheral muscles is went into a reduced endurance, and atrophy has been noticed because of low cardiovascular endurance in these patients. It has also been proved in these cases. And also another important thing is pain modulation. Are there any sort of pain modulation happens by the application of BFR? It has been noted there is an improvement in the pain, and reduction in the pain has been noticed if you are applying the BFR, low load BFR. And this one, are there any possibilities of improvement in type 2 diabetes is still under research, but this particular article, which has been released in the Trends in Endocrinology and the Metabolism, they hypothesized in this one how this BFR training could influence to reduce the blood glucose level or to improve the utility of the blood glucose in the type 2 diabetes. Hope so it will come and research or else in near future it will be a big boom in the upcoming industry. So the BFR, so if you're using it in a proper way, in a proper procedure with proper training, then it will enhance the rehab, and it will shift the recovery process, and also it will improve the performance of any patients or else even the normal individuals also. Thus, BFR is a novel treatment approach which allows the patient to reap the benefit of high intensity exercises while they are performing the low to moderate intensity workout. Okay, up to me, yes, BFR is one of an arsenal in feature in the physiotherapy rehabilitation if we are using with a proper training, proper practice, and a proper application. Thank you. Thanks very much for your time and attention.
Thank you, Mr. Ravi, for an insightful presentation. Dear viewers, if you have any questions for a speaker, please leave a comment on the chat box. Dear viewers, kindly be informed an e-certificate will be provided, and to be eligible for this certificate, you will need to fill in the survey form that can be found in the link provided in the comment section. Now the floor is open for questions. Please, Mr. Ravi. Dear viewers, the floor is open for questions. Okay. Dear Mr. Ravi, I have a few questions for you. I would like to get your insightful thought on those questions.
Yes.
So, as you have been explaining and very clearly and giving very insightful explanation regarding blood flow restriction, what will be the best position for measuring LOP?
It means the limb occlusion pressure.
Yes, please. Limb
Okay.
occlusion pressure. What will be the best position to measure limb occlusion pressure, please?
Okay, as I already told, this limb occlusion pressure is not a constant one. For it vary from person to person, as well as within the person itself. It vary from position to position. There are various things like position of the patient, and also the width of the cuff will, and also the pressure which we applied over there will vary the limb occlusion pressure. And the best thing, what the latest researchers are saying, that we have to first determine in what position we are going to perform that exercise. For example, are we going to do that exercise in supine lying, or in sitting position, or in standing position? Okay, so according to that, we have to use, if you want to do the exercises, the low load BFR in sitting position, then we have to measure the LOP in sitting position. That will be the best option. So first we have to determine in which posture or the position we plan to do that exercises, and in that position it is best to identify the limb occlusion pressure. That's the best thing.
Thank you, Mr. Ravi, for your insightful answer. So, with your permission, let me ask you one more question regarding. So,
Okay.
is it safe to use BFR and geriatric patients with high blood pressure if they are taking medication to control it? So, once again, read it for you, Mr. Ravi. Is it safe to use BFR and geriatric patients with high blood pressure if they are taking medication to control it, please?
Yeah. So that's a good question, Amicho. Okay, in the geriatric population, we have to check it. Is there any sort of fluctuations in the blood pressure? Is there? Okay, so if there is a constant fluctuation in the blood pressure, then it is suggested to avoid the training in that sort of situation. It is better to avoid it, because one of the contraindication, as we earlier put, unstable blood pressure. Okay, it is not, and also we need more research in this area, that whether all these sort of geriatric population, what they noticed is in controlled blood pressure only.
Thank you for your wonderful explanation for that question. So we have got one more question from a wonderful viewer. So let me read it for you, Mr. Ravi. Is there an age limit for this training? Once again, I repeat myself. Is there an age limit for this training, please?
There is no set age limit like that. For this one, I just recommend you guys to visit. There is one site called Kartsu.com, which is the original site from Dr. Sato, the person who invented it. He's around, the picture what I put it over there, he's around 70 plus or 80. Okay, we could able to see with him, still he is doing this workout in the one, until there is no complications or contraindications are being seen in that person. There is no age limit for this trial.
Okay, thank you, Mr. Ravi, for the wonderful explanation, for the question from a wonderful viewer. So we have one more question from a wonderful viewer. Do we need any certification or training course to be able to prescribe BFR training to our patient/client? Let me repeat myself again. Do we need any certification or training course to be able to prescribe BFR training to our patients/clients? Please, Mr. Ravi.
Yeah. Till now, we didn't have any sort of worldwide recognized organization or anything like that for BFR. But the nearest one is the Katsu Institute, which has been said by Dr. Sato. Okay, so they are providing the training through their institutions. Like I think they are working from US based one. So that is the only one recognized an institute that has been giving training for BFR.
Okay. Thank you, Mr. Ravi, for your patient and wonderful explanation regarding that question. So we have one more question from a wonderful participant. Good evening, sir. First of all, awesome topic and explained beautifully. Thank you very much for a wonderful viewer from a very good positive comment regarding our session. Beautifully, would you personally apply BFR on a patient or athlete? Once again, I repeat myself. Good evening, sir. First of all, awesome topic and explained beautifully. So, congrats, Mr. Ravi. Would you personally apply BFR on a patient or athlete? Please, Mr. Ravi.
To be very frank, no. But a few of my friends back in India, they are using it practically, and the effects have been noticed and they are published in the journals. But I yet to get that opportunity to do so.
Thank you, Mr. Ravi, for a wonderful and honest answer for the question. Thank you very much. So, dear viewers, as they say, all good things must come to an end. So, our question and answer session has come to an end. So, with that, we conclude today's session. To our dear speaker, thank you again for joining us, and especially thank you for the knowledge sharing. Once again, a sincere thanks to you, Mr. Ravi, for sharing your knowledge and expertise on this wonderful topic, wonderful, novel topic. Thank you very much. To our keen and attentive viewers, thank you for joining our webinar. We look forward to your comments and participation in our future events hosted by MAHSA University. For further queries, please contact us through the MAHSA website or visit our social media. Once again, we welcome you for your kind participation in the upcoming MHS conference hosted by MAHSA University. Please join us in the journey of excellence and extend your kind support. So once again, a sincere thanks to our speaker and to all the wonderful participants for making this evening memorable. Wishing you everyone a pleasant evening. Thank you very much for joining us. Thank you.